Okay. So we've actually been in communication about this process for the last few days, and but it's not perfect. So I'm going to talk about, what does that mean? Louder? Louder? Can I make this louder?
No.
Nope.
You're going to have to speak louder.
I got to talk louder. I can do that. I can talk loud. So why is this? Dr. Chopra was talking about a red flag being that the person who, if you're in the doctor's office and the doctor is more interested in having you go and see a psychiatrist than in learning about your problem, that's not a good sign. And in fact, in most cases, it's a pretty bad sign. In some cases, it's not such a bad sign. But what I want to do is try to sort of move from the whole problem of, I guess yesterday people were talking about Munchausen and medical child abuse and so forth. And this whole business of somatoform disorders is a little bit different in that the concern that comes up is that the blame essentially for the problem gets put on the child and the child's sort of psychological functioning rather than on the parent, and it can go badly. So I'd just like to sort of help you to understand something about what this whole realm is really about, and so that if it comes up, you'll be able to respond to it in a way that will not be terrible. The reality is that in situations where the issue becomes whether or not the child has a somatoform disorder, psychosomatic disorder, whatever you want to call it, the situation is usually clinically more positive than it is in situations where the allegation is that parents have been promoting ill health in some way or another for the child. So it can be okay, but it can still be difficult. So here's the first question. How many of you have actually heard in these words from a medical provider, it's all in her head? Raise your hand. All in her head, really? Like that. That's remarkable. Okay. Because there are lots of more polite ways of saying it, like these. What about this? Can't find anything wrong with her physically. She's probably experiencing a lot of stress. Duh. She just needs to go to school. She'll feel better. Yeah. It's a functional problem. That's a good one. Like, okay, yeah, of course it is. She's not functioning. And she has conversion disorder. What about this? That's a popular one. Okay. So, what's happening here? So, have you, how many have received a recommendation to get psychological help in response to these sorts of things? Okay. And how many of you have found it useful? Good. That's wonderful. Okay, a few. Not too many, but now how many of you have felt puzzled? Not a few, yes. Frustrated? Okay. Confused? Yeah. Abandoned? Awesome. So what it actually means when doctors tell you this sort of thing is something different from how people usually experience it. What it actually means is the doctor's saying, we don't really know everything that's going on with her. Maybe there's some psychological problem that's contributing to her symptoms. It might be helpful for her to meet with an expert in psychological issues. Not sort of a terrible thing. And on the other hand, what you may hear when you hear this sort of thing is there's absolutely nothing wrong with her physically, period. She's crazy. She's a whack job. She's got a screw loose. She needs to get her head examined. There's really nothing else that's going to help her. Good, right? So what may happen next is you feel insulted. You get angry. They get defensive in response to your being angry. They suggest that you're not doing a good job as a parent because, after all, you're angry when they're just doing their job as a doctor and trying to help you. And they turn their backs on you and stop talking to you. They write accusatory entries in the medical record that will negatively influence other providers. Not really a good thing. And they may call Child Protective Services and claim that this is a case of medical child abuse, which is, in fact, the generally worst way that things like this can unfold. Now, for the child, the experience of being accused of not really being sick is something that causes profound invalidation, and the common reactions that children have to this experience include, unfortunately, an increased determination to embrace the sick role. You're telling me I'm not sick? I'll show you I'm sick. And a stubborn resistance to any suggestion that psychological help might be worthwhile. No, I'm not going to do that stupid therapy. I'm sick. It's a physical problem. Leave me alone. I'm not going. No. You can't. I'm not going to think about sort of happy days on the beach and relax and so forth. Leave me alone. So this is a video of Karen Richards, who actually said that she was going to be here today. Probably many of you know her. This is a clip that was made 3 years ago when she was 13, and I will do my best to control it. It's like I wasn't able to figure out how to edit it so that this happens automatically. So, oh, okay. Well, if we don't have sound, that's going to be a problem. We'll find out if we have any sound. Where is this thing happening? All right. So, what does that say? 14?
6, 19.
All right.
10, 46.
Oops. All right, so that didn't work. I'm supposed to hit this one. Okay. Is she? There's the sound. Okay, wait. Oh, I'm sorry.
Here. If you get it started, I'll try to make it begin. It's starting, so. Then just let it go and then move it. Can you hear it?
I can barely hear it.
Can you turn the volume up on your machine?
The volume is up as far as it'll go in the machine. All right, hang on.
Around Boston forever. Just walk.
12. Oh, come on, where is that?
So finally, we just to
This is it.
the big Boston hospital.
I don't know.
Where's the speaker?
Sound's coming out.
It's supposed to be the best, right? And I got there and
All right,
saw
we'll
me.
go back just a bit. So,
I don't know.
you know,
it's just this
I'm just going to skip
world
this. It's just going to be too complicated. I'm sorry. It's a great clip, but it's just not going to work. So let's go on.
There's no way.
So what she's talking about is, in the first place, an experience of showing up in the emergency room and getting this feeling right from the start that she wasn't being believed, that the symptoms that she was having, which were significant asthmatic problems were not actually asthma. In fact, it turns out that it wasn't asthma, as she points out generously, but the feeling that she got was of just not being listened to, being disbelieved and treated like crap. And then in the next section, she goes on to talk about the problem of being diagnosed with conversion disorder and we'll get to what conversion disorder actually means, but all of you understand that what it really means is she's a whack job, you know. She's not sick. And so in response to that, she goes on with really poignant articulation about how unfair that experience felt to her, and how much it interfered with her. Well, with the clip itself doesn't really go into detail, but in fact, the course was that it sort of contributed greatly to the difficulties that she subsequently had with getting appropriate care and dealing with the difficulties that all these problems caused her. Anyway, so let's talk now about the whole problem of somatoform disorders. There are basically three named conditions that are worth mentioning in the psychiatric nomenclature, the big sort of DSM-5 book about sort of all the reality, if whatever you think of it. So the first of these is the somatic symptom disorder. And what that means is the first criterion for this diagnosis is that there's one or more somatic symptoms that are distressing or result in significant disruption of daily life. Now, the important thing to notice here is that there is not, in fact, any requirement that the person not have a real medical illness. In other words, this is a diagnosis that can be made in the presence of a real medical illness if the thoughts, feelings, or behaviors related to the symptoms or associated health concerns are excessive. Okay? So if the doctor thinks that you're like too worried about what's wrong with you, you can be diagnosed with a mental illness, somatic symptom disorder. The bad news about that, of course, is, you know, it may not be excessive concern. The good news is that under some circumstances, in fact many circumstances, it's probably worthwhile to be paying attention to the emotional factors that go along with being sick and trying to respond to them in some way that is helpful, which I think is why the definition of this condition was changed to allow real illness to be included among the category of somatic symptom disorders. The thoughts and feelings are supposed to be disproportionate. There's a persistently high level of anxiety. There's excessive time and energy devoted to the symptoms or health concerns. In other words, you know, you've got a problem, but you're just too upset about it. That's the deal. That qualifies you for a diagnosis of somatic symptom disorder. It's actually very simple. The next condition is called illness anxiety disorder, which basically is just a fancy name for hypochondriasis. It means that you're nervous about being sick, even though you're not sick, even though you don't actually have any symptoms other than being worried about being sick. And we don't really need to spend any more time on that because it's not really that germane to what I think most of you have experienced. Conversion disorder is now something that's limited to neurological symptoms. So somebody with a stomach ache who they can't sort of find out what the problem is won't qualify for a conversion disorder diagnosis. But someone who has neurological symptoms that are clearly not consistent with what we know about how the nervous system works can be diagnosed with conversion disorder. This is different from the somatic symptom disorder because in this case it is required that the symptom not be consistent with what we know about physical functioning. So the rest of this is sort of not really worth paying a lot of time to. So with that as background, let's return to what happens between you and the doctor and how it might go better. In the first place, here are some basic assumptions that I took from a slide at a presentation that I was at last month at the American Academy of Child Psychiatry in New York. This is from a woman named Brenda Birch, who wrote a wonderful book called How Many More Questions, which describes just wonderfully good ideas about how to talk with children about their medical problems in ways that the children can actually tolerate. Here are the things that she cites as basic assumptions in this area. She was talking about pain, but in fact, all these things apply just as well to everything else as they do to pain. All pain is biological and influenced by complex biological processes, including physical factors, cognitive and psychological factors, and social cultural context. Maintaining the organic versus non-organic dichotomy is misleading and can be harmful. It's harmful in that it can lead to unneeded procedures and medical treatments on the one hand, and to a detrimental lack of empathy on the other hand. I'm sure everyone's familiar with those problems. To evaluate and treat symptoms efficiently and effectively, we must abandon the mind-body duality. Now, she also sort of offered a variety of quizzes in this presentation, and the first one, the one that I really love, is the following. When someone is in pain, how much of the pain, what percentage of the pain is physical? Any guesses? The answer is 100%. When someone is in pain, how much of the pain is emotional? Guesses? The answer is 100%. So that's the point. I mean, you can't take them apart. Anytime you look in detail at what the physiology is of pain experiences, when you get down to the cellular level and the tissue level, what you discover is that there are incredibly complex connections between the sort of specific cells involved, for example, in the gastrointestinal tract mucosa, the immune system, the nervous system, the brain. It's just all, they're all interacting with each other, and so it doesn't make any sense in any way at all to try to draw a distinction between physical on the one hand and psychological on the other. So here's what should happen in this interaction with doctors. They say, instead of saying that she's a whack job, she's nothing wrong with her, they say, we've tried everything we know to figure out what the problem is, but all we have found out is that it's not any of the things we've tested for. Obviously, if the problem is not something we have tested for, that means it must be something that we don't know about. Refreshing modesty, you know. We understand that this is probably very frustrating for you, just as it is for us. Now, in response, you say, no, duh. And then you say, well, yes, it certainly is frustrating and very scary, too. Since she's clearly in a lot of distress and nobody seems to know what to do to help her. And you go on to say, and then they say, well, Scary is right, this is a hugely stressful situation for her and for the whole family. We'll continue to do whatever we can to figure out what the problem is, research, consultations, everything there is to do. But in the meantime, what we have found out is that when families are up against this kind of frustration, it can be very helpful to have someone working with you who can provide support and help you figure out how best to cope. So we'd like to introduce you to our colleague, Dr. Shrink, and have her join the team of professionals trying to help you and your daughter. Please understand that this introduction is in no way reflects any suggestion that your daughter is crazy or otherwise mentally ill. Instead, it reflects our understanding of how difficult it is to find yourselves in a situation like this, and our experience that what works best in responding to this kind of situation is a team approach addressing both the physical and the emotional aspects of her problem. And of course, we will look forward to seeing you back here in 6 weeks to follow up with us as we continue trying to figure out the physical aspects of this problem that she has. And then in response, you say, "Thank you so much for your persistence and thoughtful support. We are very happy to meet Dr. Shrink, and we look forward to continuing to work with her and with you to solve this problem together." What happened? Oh. Simple enough, right? It's a pretty good deal. Everything's happy. Now, in reality, I haven't been able to find any legitimate disagreement in the field as to whether this approach is right or not. Everyone seems to agree, yes, this is the right way to think about things. This is the right way to approach it. And yet, there still are significant problems. In the first place, there are not very many programs that are set up to provide the kind of coordinated teamwork approach to addressing both the physical and the emotional aspects of complex disorders in a way that is actually helpful. What you're mostly going to find is, at best, efforts to make a referral or, the ideal is to have everybody working in the same clinic, to have the introductions sort of in person in the office at the same time, and to have everybody in communication all the time. That's not a common thing in terms of the way the system works. And even when it happens, I can tell you that there are providers of mental health services who, even when working in that kind of coordinated teamwork approach, can be patronizing and off-putting and can interfere with the process of arriving at a sound, encouraging, empowering vision of what the nature of the problem is and how best to deal with both the physical and the emotional aspects of it at the same time. One of the presentations, a different presentation that I went to at this meeting, included a sort of leading commentary by a psychiatrist who works in, a coordinated, pain, clinic setting kind of thing. And basically what he started off with in talking about how to deal with a somatoform problem was that the doctor's first job is to, quote, decode the symptoms, the complaints. In other words, the basic assumption still being they're not real. They're an expression of emotional disorder in some way or another. And this is somebody who actually works in the kind of setting where everything ought to work the right way. And in fact, he went on to talk about the interaction between emotional problems and physical problems in exactly the way I've described. It doesn't make sense to take them apart. They have to be addressed holistically. But it turns out that even though he sort of understands that and says that, clearly his attitude about sort of what's going on in this kind of situation was not informed by that understanding. And unfortunately, that's a common problem. So here's my advice. Be careful. I think of this advice as similar to the advice that minority parents give their children when they live in a disadvantaged neighborhood and they are expecting to have dealings with the police in the neighborhood, and the advice is always be polite, pay attention, don't stir things up, take care, you're in danger. And in reality, I think that's a good attitude to have under these conditions. Be careful, but don't be paranoid. Don't sort of give don't assume that the attitude will be bad. Listen, respond, contribute what you can to the creation of a positive attitude. And by that I mean understand that, in fact, when there are concerns about physical symptoms that are elusive in their physical diagnosis and may be in association with some kind of emotional concern, understand that that's not, it shouldn't be, even though sometimes it may be, it shouldn't be an accusation of making it up or faking. What it should be is an acknowledgement that indeed, whenever anybody is suffering from a complex physical problem, and especially a complex problem that is hard to diagnose and that is not getting better, it's going to be stressful and it's going to contribute to any number of complicated different kinds of psychological responses that may in fact tend to make the situation worse. And so what you ideally will be looking for is a kind of help that will include both continuing to look into the physical problem and what it actually represents, and also help in developing improved ways of understanding the whole range of problems that this brings with it, and having an emotional sort of positiveness about tackling the problem and not being overwhelmed by it. So that's really all I have to say, and I'm happy to engage in any kind of discussion about it. Questions, comments? Yes?
When you're diagnosed with a psychological, like you say, making it up, and there's physical symptoms, and then you find out it's a brain tumor, it's a risk, and the records keep still saying you have, it's a psychological problem, and the only way I conquered it was to come back with the radiation records from another facility and turn them into the records. Do you have any other suggestions on how to counter that?
For those who didn't hear the question is when someone's been diagnosed with a somatoform concern and it turns out that subsequently it becomes obvious that the symptoms were the result of a clear-cut physical problem like a tumor, but the record continues to reflect this false diagnosis. How does one deal with that? How does one prevent subsequent providers from continuing to be skeptical and sort of not understand that there really is this important physical problem that needs to be addressed? And frankly, I think it's a hard problem, and I don't have any particular sort of well-informed recommendations about how to deal with it, except to do what you described, which is to obtain documentation of the subsequent diagnosis and bring it back to the sort of previous provider and hope that the record will be adjusted. But eager to hear any other ideas about this. Is John Martin still in the room?
I am.
What, do you have any ideas about this?
I was going to ask you.
Well, you can enter an amendment, and even if they reject the amendment in the presence of a report for radiation for a brain tumor and an MRI, that still stands in the record, and the doctor kind of looks stupid to reject it, because you already had the radiation for the brain tumors.
Did everybody hear that? Basically, one response is to sort of provide the documentation and expect that the record will be amended, and then,
No, you have to submit an amendment.
oh, submit an amendment.
If under HIPAA law,
Oh, okay.
you have to submit an amendment in order, if the doctor won't correct it, the patient has the right to submit an amendment. And this is federal. And if the doctor says, oh no, UCLA must have made up this brain tumor and given you fake radiation, then that stands in the record. And generally, then it gets bumped up to the department head and then risk management to try and explain to the doctor that, gee, she already had radiation for the brain tumor.
Okay.
She has.
Does everybody hear that? The important news is that within federal medical records law, there's this process for submitting a request to have your record amended, which then will happen, and the provider will have to figure out a way to deal with it. Mark, you had a thought.
Yeah, a couple of things. One is if a member of the core team recognizes that it is a significant error, he or she can actually write really a separate note just to address that and send it to other members of the team, and it will be put on the record. The other thing is, especially in situations where some unfortunate situation happens in the doctor's office where you have a different perspective on what is going on or what happened in a clinic event, at a clinic session, and the doctor records it from his or her perspective, then it sort of does you a disservice by not having your perspective reflected in the medical record. But there's nothing to say that you can't write the doctor a letter or some other member of the team a letter who can then make sure it is included in the medical record. So you can't change your record. You can't change your record once it's signed off, but you can add to it.
The doctor can amend the record himself, herself, or they can cross it out. They
No,
can't change
they
it.
can't change it. They can only add to it.
That's
That's
the
right.
amendment. You add
Yes.
to it. So,
So basically, the amendment would read, this is Dr. Corson with further commentary on this patient. I was wrong before. Here's the right answer.
well, the brain tumor treatment notes were submitted as the amendment, along with a few kindly worded letters from my core team.
Yeah.
which was
Not
gratifying.
only was I wrong, but the documentation of my being wrong is followed right here in the record. Amanda?
What I find interesting is that, so she, in this case, she was misdiagnosed, correct? It's not agree on that. Okay, so the doctors acknowledge that she had treatment, but we can't remove that from the record. But on the flip side, you can go in with a medical diagnosis into an emergency room and have that removed instantly by someone that just met you, and then change that diagnosis to somatoform or some other bizarre diagnosis. And it's happened to people, you don't really have that doctor's not right, they're not an expert. Where's the burden of proof on that medical professional to prove that they have extensive knowledge and that patient does not have that? Is there any burden of proof?
I had 8 different opinions on having a brain tumor, and one opinion that didn't, and I was trying to change that.
Yeah, that's confounding to me, and it's happening. And I think that you guys have, I respect you and appreciate you so much. And I think you're an important part of the team. I think it's underrated, the stigma that's been put on chronically complex ill patients, to admit psychological and complex
That's my point. No one will not have both, of course.
Right. Yeah, it's a natural fit. So I don't know. I get, we have a national organization, I get people that come and say that they've been labeled by a psychiatrist and then no one would look for their underlying cause. And then I've had other people that went to a psychiatrist and had really great experiences and were told that they had somatic problems. The psychiatrist said, no, you have, that sounds like POTS. That sounds like you have a Gamma syndrome. So they can be diagnostically fantastic and helpful. And people like you, especially, are so valuable in the community. I don't know how to bridge the gap between the anxiety of opening up, or, I don't want to push people there and put them in harm's way, but what do you recommend? How can we vet our psychiatrists sort of in the community?
Well, one thing I can think of is by, sort of talking with other people who've had, contact with them and sort of what sort of recommendations you get. But Jessica, you had a thought.
Yeah, I was actually just going to say you can continue commenting on this because I'm interested in hearing your response. That one of the things that I advise patients who are dealing with complex medical conditions where there's a high probability of a psychiatric misdiagnosis, such as a teenage girl with GI problems. Very high probability of a misdiagnosis of an eating disorder or another psychiatric issue. I often tell them too that the best defense is a good offense in this situation, to go out and find a good psychiatrist, make that doctor a member of their team, get to know the child, get to know the medical history, so that way when they go into emergency rooms and other settings and get a psych label thrown at them sort of reflexively, they can say, no, wait a minute, I have a psychiatrist. Here's his or her name and number, call them up. They don't think I have an eating disorder. They've already considered the possibility and ruled it out. And that this has actually been one of the most successful ways of cutting down on psychiatric misdiagnoses, is to make a mental health provider a long-standing member of your medical team.
Right.
And when Amanda was asking about how to vet doctors, patient community, like you said, but also go online and look to see if they've published and what they've published in. That's how I learned about you. Is I went online and I checked out the articles that you had worked on, and I found your excellent piece about your case study on one of your patients with a psychiatric misdiagnosis, and I read your thoughtful response, and I was like, hey, this diagnosis is going on. And that's how I understood that you would be a valuable part of, a team for people with complex medical conditions.
Right, and in fact, the case in that article was Karen Richards, who I had hoped that you'd be able to learn from today. And when I started working with her, the way that I was successful in getting around the defensiveness that she had about working with any kind of mental health professional, because in fact, she wasn't making it up, and she didn't want to be thought of as making it up. But what worked was to help her to understand that, just as you say, if she has her own psychiatrist, she's protected. She can basically say, I have a psychiatrist. It's all taken care of. I'm getting help. For that, let's get to work on my EDS. Yeah.
Okay.
Oh, we have to go on? Okay. Yeah, I'll be here.
Okay. We need to stop and take a break, and we'll be starting up again at 10:40. So